Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Today we're going to focus on two developmental issues that have a lot of media coverage and a high level of public awareness, but also a lot of misconceptions, assumptions and speculation. These are Attention Deficit Hyperactivity Disorder and Autism Spectrum Disorder. Later in the programme we'll talk with Professor Trevor Parry about autism, but first up we're joined by Dr. Stephanie Grief. Stephanie is a developmental paediatrician, and those of you who were at our recent annual conference may have seen her give a presentation on ADHD. Dr. Olga Ward caught up with her at the annual conference.
Stephanie, welcome to the program.
Thank you.
Stephanie, tell me a little bit about ADHD. How do you differentiate between a child with an actual disorder and a child who's just got very poor boundaries or very erratic parenting?
That's a very good question. Just to elaborate, ADHD is, as you know, Attention Deficit Hyperactivity Disorder, and it describes the behaviour of children which is either hyperactive or inattentive. And there are three different types. There's a predominantly inattentive type, predominantly hyperactive type, and then a combined type.
Okay, well, hyperactive, I can imagine those are the children that are boinging off the walls and trashing things.
That's right, yes.
Inattentive kids, could you maybe describe what they look like or what they do?
Those kids are generally the kids that the teacher would describe as being dreamy in class, unable to concentrate. At home, they would be described as those kids that need to be reminded 10 times to get their school shoes on, and really frustrating the parents to get out the door. So they're unable to focus on the tasks at hand. And just going back to your previous question about just differentiating these children from the children that come from chaotic backgrounds, it's important to realise that we don't really know the cause of ADHD, but often children that come from chaotic backgrounds have parents who have ADHD, which is not well managed, and this can contribute to the environment that can sort of fuel the diagnosis.
So contrary to previous belief, this is definitely a lifelong disorder?
That's right.
You don't grow out of it or mature out of it?
We used to think that, generally children can grow out of it. There are some studies to show that as the neuronal development improves, or there's maturational improvement of the brain, that children or adolescents can control their condition better, so they may need less medication, or they may be able to go off medication, but they may still have the disorder into adulthood.
Talking about a lifelong thing, how early do you see this kind of behaviour? Like, would you pick it up in babies or small toddlers?
You can certainly, retrospectively, when you're looking at a school-going child, that there are some signs that would come up in history that the child was either a very busy toddler, or that the baby was quite a fussy or alert baby. But you certainly wouldn't make a diagnosis that young. You wouldn't diagnose a 2-year-old with ADHD as their hyperactivity could be well within normal for the developmental age. And that's the important thing about making a diagnosis, is that it is out of norm for what would be expected at that developmental age for the child.
And does it run in families? Like, if you've got parents with one child with ADHD, can you at least assure them that all their children are not going to have ADHD?
That's certainly not the case. Although we don't really know how the genetics or inheritance works, there is definitely a possibility that other children might be more at risk. Could be related to the family environment, and it could be related to the parents having the condition too.
Mm-hmm. Now, if you picked it up relatively early, in those few preschool or early school years, what sort of treatment would you recommend? And how early do you give medication, and what other things are around?
I think the most important thing is to make sure that you have made the right diagnosis, because we don't want to label children unnecessarily. That's why often the diagnosis can take a while and might need 1 or 2 appointments to get information from other sources. In order to make a diagnosis, we follow the DSM-4 or DSM-5 criteria, and that stipulates that the characteristics or the behaviours should be present in more than two or more settings. So they should be present at school and at home or any other setting. And once you have made the diagnosis, then you would decide on whether you could just start with some psychosocial interventions, perhaps getting some psychological help for the family and the children. setting some strategies in place to help the family and to help the child at school, informing the school about what strategies need to be in place.
What sort of strategies are you talking about? Given that quite often in a country town it's the GP who's going to have to suggest them, and we aren't school psychs by any stretch.
No, I agree, and I think that can be a challenge for many GPs. I think it's important for the parents to understand the condition and to realise that children might not be able to process, many instructions at once, and they need stepwise instructions. Often these need to be written down so that they can follow them, and often visual aids help. And then also being consistent with certain behavioural abnormal or difficulties that they experience, that they're consistent in setting boundaries that these children can try and follow. And then obviously if these things don't work, then we would consider medication. So medication generally for a child, we wouldn't really consider medication in a young child, less than 5, probably unless they're very extreme. Children that are school-going age from about 6 onwards, many certainly respond to medication, and certainly we can start medication any time during the course of treatment. We give children about a 6 to 8 week trial of treatment, depending on how they respond, and then we manage accordingly.
Yeah. When the parents are making a decision about whether or not to try medication, what sort of informational background can the GP give them about side effects, and how is it going to affect your child's growth, and all of those things that parents worry about? Are they going to have to take it forever, and
yes,
just in school terms?
That's a common question I get asked all the time. I think it's important when you start medication to warn the parents that the child is going to have side effects. I don't think there's any point in telling them that it's fine, because it isn't. A lot of children do get quite agitated in the first couple of weeks, especially in the late afternoon when the medication wears off. It can affect heart rates and it can affect blood pressure, so these are things that need to be monitored.
So are they actually going through something like an amphetamine withdrawal, or is it just their normal agitation reasserting itself as it's not really a sedative effect, but has a calming effect wears off?
Possibly there's a rebound effect, so during the day when they're on medication they're able to focus and channel their energies, but once the medication comes off there's this rebound, and they certainly do get quite agitated. Another thing is that it can affect the appetite, and then further down the line they might have a bit of weight loss. Just importantly to remember for GPs, if they are monitoring children that are in treatment, that weight loss or poor sleeping should never be tolerated, and these should really be reassessed and managed, and doses adjusted or treatment changed.
And what happens if the medication doesn't work or has unacceptable side effects? How many options have you got? Yeah,
there are quite a few options. Importantly, that some children that do have the side effects on the short-acting or the stimulants that we start off with, they might respond better to a long-acting or controlled-release preparation, which is still methylphenidate in a long-acting form like Ritalin LA or Concerta. Children often have less side effects on those medications. If they do not respond or do not tolerate any of the stimulants, then we could consider something like Strattera or atomoxetine, although this is usually in the older child, and there are
I'm not familiar with either of those.
Okay.
Are they also, they're not stimulants, obviously?
Well, it's one drug. Strattera is atomoxetine. It's a non-stimulant, and but there are other side effects related to that, and children can get quite severe mood disorders related to that medication. But that would be something that we would only consider once we have made sure that we're using the right dose and the correct controlled release preparation of stimulants on a child.
Say the kiddie does absolutely brilliantly on Ritalin. Are they going to continue to do brilliantly on Ritalin for their whole, childhood and adolescence, or do you just change the doses, they get bigger and heavier, or do you have to look at changing agent each time?
Not each time, but there are certainly, and I think that can be quite challenging dealing with these children, because as they grow their needs change. Often the condition can change from being quite hyperactive in early childhood to being more inattentive in adolescence. So it's important to recognise those symptoms and to use the adolescent to help you, to guide you with which medication would be useful. The dosage sometimes obviously needs to be adjusted in the early years when the weight gain is quite rapid. Also depending on the metabolism, rapid metabolisms might need high doses of medication. Later on in adolescence, if adolescents are able to manage their condition better, then you might be able to reduce the dose and then manage it into adulthood.
I hear about patients who have their kids on their medication during term time, and then they get to the school holidays and they give them a drug holiday. And, you know, superficially that sounds like not a bad idea, but does that mean that the kids just simply get out of routine and go to mush during the holidays and then have to kind of struggle to catch up at the beginning of the term, or is it a kind of an instantaneous switch on, switch off thing?
The thing about the stimulants that we use is that they are quite short acting, they have short half-lives, so generally they do wear off quite quickly, and there's no sort of entity where you need to wean yourself off the medication, so they can be stopped immediately. We used to encourage drug holidays because we thought that perhaps the children would benefit, and the only benefit they needed was at school. But now we see that children do need the medication to help them to develop social relationships, to help them to you know, even with their sports that they do, to help them focus and manage those sports. So we generally say that they should be on the medication all the time. Unfortunately, there are some children that do need medication and quite high doses that might need those medication during to help them at school. And if this does impact on their weight and their appetite, then it certainly does make sense for us to maybe drop the dose during holidays or during weekends, just to give them a time to gain weight. But that's why it's important that we do watch these kids very closely and monitor them. I understand that it can be difficult in rural areas where the paediatrician may not visit, you know, for a few months at a time. So that's why the general practitioners are so wonderful resource and able to monitor those children and keep an eye on their weights.
What sort of programs are available for country kids?
Depends on the town you're in, I guess. And a lot of the child development centres do have workshops for specifically ADHD children, but others would generally have workshops or support available for children with behavioural difficulties, or just generally for parenting. And any parent would benefit from these courses like Triple P or Mindful Parenting course. There are a lot of web resources available, and in Perth there is the LADS, or Learning and Attentive Deficiency Society. And this is quite a nice web resource, and they do have a helpline specifically for ADHD that parents can phone. Even though they may not be in Perth, they can phone from the rural areas to get support and advice on what programs are available.
I see that there are lots of labels for children these days, and I'm finding them awfully difficult to keep up with. I hear about things, other behavioural disorders, oppositional defiant disorder, and aren't they just naughty kids? How do you kind of find a label for these children? Where does it become a disorder?
Absolutely. Oppositional defiant disorder is a psychiatric disorder, and it also relates to behaviour, which is persistently defiant, and it usually has to last for about 6 months. There's a common comorbidity in children with ADHD that do have oppositional defiant disorder, probably about maybe in some studies up to about 40%. So there certainly is a link between ODD, or oppositional defiant disorder, and ADHD. I agree that it's really important that the diagnosis needs to be made by the correct, using the correct tools. We don't want to label children unnecessarily, because these labels will be with them for quite a while. These children can be managed. Often when we do get a child with possible ODD, we try and use the psychiatrist to help us make that diagnosis. That can be quite useful, using CAMS, or Child and Adolescent Mental Health Service. And these children can be helped to a certain degree. Medication certainly is useful. Those children have ADHD as a comorbid feature, and then also psychosocial support. It's really important that these children are followed up into adolescence, because if they are not well managed, then that's where you do get some serious problems arising, and conduct disorder can be something that could be related to that.
What about the kids with fetal alcohol syndrome, who really don't have a lot of frontal lobe function and can't learn from their mistakes sometimes? How do you kind of pick them out from the other behavioural disorders.
That's right. Fetal alcohol syndrome certainly has ADHD as a comorbid feature. It is not really certain whether the ADHD is a different entity or whether it is the same ADHD that other children that without fetal alcohol syndrome have. And sometimes it's important to try and look for these diagnoses. We know that children with fetal alcohol syndrome have other problems like learning difficulties or speech and language problems. So therefore, ADHD as a separate diagnosis can help those children if you focus your treatment and management according to that diagnosis. I just heard or read the other day in the newspaper that they might be recognising fetal alcohol syndrome as a disability, which I think would be useful as these children might be able to get additional support to help with their condition.
Yeah. So what kind of management and resources are available to kids who are in this almost multiple pathology? They've got fetal alcohol and they've got a behaviour disorder, or they've got some other group of syndromes. Who are the people who can most help them?
Well, I think it's important, as at this stage, children with fetal alcohol syndrome don't really get any specific support for that diagnosis. And I think it is going to be quite difficult, to diagnose these children because often they don't really have many of the dysmorphic features that the more severe children do. But just generally, your allied health professionals are, excellent at managing the associated conditions or related abnormalities or difficulties that child may have. For example, your occupational therapist to help with any handwriting or fine motor skills, and then your speech and language pathologists that help with the language difficulties. Certainly the educational psychologists are vital to help with these children to identify any learning difficulties and to provide the necessary support that these children might need, specific behaviour or specific learning tools in the classroom that would help them to manage their condition at school and to help the teachers accommodate them.
Are there any other behavioural disorders that are really difficult to diagnose or more common than we might imagine?
The extremely anxious child, these children can often present with some significant behavioural difficulties, and then children with speech delay or with hearing difficulties certainly present with some behavioural problems. So that's why it's always important to make sure that a full and thorough history is taken, as well as a good examination. Other problems like iron deficiency anemia can present with some behavioural difficulties and difficulties at school, so it's important to exclude that as well.
Okay, so then we'd be looking for something nutritional or absorption.
That's right, yes.
So, I mean, the interactions that GPs have with small kids are often limited to immunisations and coughs and colds, so we're screening for this kind of thing whilst we're dealing with the problem in front.
That's right, and I think it can be really difficult if you have a short consultation. You don't really want to open up a can of worms and ask how things are going at school when you're going to get, the whole thing bombarded on you. But that really is important for the child, as the child and the family will only benefit from any interventions that you set in place to help that child.
Yeah. What about managing difficult behaviours in kids that are already disabled? For example, the children with cerebral palsy that sometimes become quite manipulative to make the family run around and do things for them. How do you kind of, they become either extremely attention-seeking or quite dependent. How do you help the parents kind of not to play along with that and give them some positive stuff to go on with?
I think it's important for parents to be consistent and to, if they have set certain boundaries, that they maintain those boundaries. At the same time, for children that have a severe intellectual disability, it's important to try and be able to communicate with the child. So if the child is nonverbal, that they do learn tools to be able to communicate their needs and wants, because that will ultimately help them with their frustrations. Also, some children with severe nonverbal autism have anxiety, and often this anxiety can be heightened in unfamiliar situations, and parents need to try and predict which situations will be quite difficult for the children to manage so that they can prevent any serious meltdowns. Another thing is that parents with children with disabilities do often need a bit of a break, and a bit of respite can be useful to help them to recharge their batteries so that they can come back to their family and provide the best support.
Yeah. Stephanie, you've mentioned anxiety several times. Managing anxiety in kids, is that purely a psychological strategies, or do we actually have to look at pharmacology as well?
We certainly try psychological strategies first, and it appears that there are quite a lot of children that are anxious that might be not really getting the help that they need. We do look at medication. I generally try to stay away from managing too much anxiety in my clinic, as I feel that perhaps the psychiatrists probably have more to contribute and are better at managing severe anxiety disorders. So certainly they would prescribe some pharmacological treatments to help with those children. But I think psychosocial support would be your first port of call.
Yeah, and if you do end up resorting to the pharmacology, what sort of drugs are suitable for use in small children?
Sometimes with children with autism, we can use some of the SSRIs they're probably the best thing for children with anxiety or depression. And then children with that have severe anxiety that causes things like aggression or violence, we might try some of the stronger antipsychotics like risperidone, which has been registered for use in children with autism.
Stephanie, could you tell me about some of these tools and strategies that the allied health people use? We don't get much of a chance to see what they're doing from our general practices, but I guess you've got a bit more idea of what practically goes on.
Yes, I think it's important to remember that the allied health professionals have amazing skills and tools, and that can certainly help these children. The occupational therapists, for instance, they can use, they have developed lap bags or weighted blankets to help the children. They can use these in the classroom, so they can sit on the chair and stay seated, and just having that weight on their lap helps them focus their attention and do their work in the classroom. Mm-hmm. Other things that they could use, stress balls or blue tack in their fingers to help them keeping that movement, because that can often help just settle their anxiety or their need to move about and to be active and busy. Mm-hmm. The physiotherapists also help with developing. A lot of the children with ADHD do have some difficulties with motor planning and coordination, and they can help with strengthening upper body. This is important because this helps them ultimately with their fine motor skills and their writing. So, and children at home can also be helped along with these strategies. They can help with monkey bars. Monkey bars build upper body strength, and this ultimately helps with these children focus on their handwriting. Because these children, if a child, especially a child with inattentive ADHD, is unable to support the trunk and write, and they're at the same time unable to focus, this can ultimately lead to problems in the classroom with their learning, and they're unable to obtain or maximize their time in the classroom.
So just doing things like, say, getting the kids to walk to school. If you've got somebody with inattentive ADHD, I guess getting them to walk to school on a traffic-laden street isn't such a good plan. Is that the sort of activity you mean, or do they need to go hard and fast, playing rough games in the school playground?
No, I think walking to school is great, and any child that has, if you can incorporate that physical activity in day-to-day living, it makes it much easier for the family. So walking to school, or if you can ride a bike with them to school, I think that is great. And I appreciate the difficulties in busy towns, but in country towns, maybe that might be a little bit easier. Often that walk to school, might be a little bit of an outlet for those children to get, maybe burn off some of that energy to help them, so that when they do get to school, that they can better focus. I think it's also important to remember that children also need to eat well-balanced diet and healthy food. A lot of the foods that the children eat today have got quite a lot of sugar in them, and this can result in them having swings up and down in their blood sugar, and unable to, if they do feel hungry, they can often exacerbate their symptoms. So I think it's important that children do eat a good balanced healthy diet with all the necessary proteins.
So all that stuff about red cordial gives you ADHD, or yellow food colouring or whatever, actually it was the sugar in the lollies and the cordial that was the problem?
I must say I can't really confirm any of that, as I haven't done any research, but I do believe it's quite it's quite obvious that that too much sugar or foods that are very processed do play havoc with the blood sugar, and I think that it's important that parents realise that sometimes the children's moods may be related to what they're eating, although we can't really prove it because it would be very difficult to do a trial and double-blind whatever trial to assess these on families. But I think it makes common sense that if you do have children that do have some behavioural difficulties, that if they have good, healthy, solid meals, that can give them the best start. I'm not saying that diet is the way to manage ADHD, but I think any child, whether they have ADHD or not, would benefit from a healthy, balanced diet.
And thanks very much to Dr. Stephanie Grief for being a part of the program and for her presentation at the Rural Health West Annual Conference. Well, another developmental issue that seems to have a lot of misconceptions surrounding it is autism. Because of how broad the autism spectrum is, a diagnosis can be very confusing and confronting for the parents and the family. We spoke with Professor Trevor Parry from UWA and Princess Margaret Hospital about the autism spectrum and the process of making a diagnosis.
Trevor, welcome to the program.
Thank you, Olga.
Autism seems to be very prevalent in our community at the moment. Could you talk to us a little bit about the diagnosis of autism and what it really means?
Thank you. Yes, it has become a big demand in paediatrics, particularly in developmental paediatrics, and I can see the GPs get asked this question a lot. The prevalence, which when I was an undergraduate was probably thought to be 1 in 10,000 or something of that order. Australian data, and confirmed in other places, is showing a population incidence of 1 in 160. Which makes it commoner than any other developmental disorder that we have. What is autism? I think that the triad is still a useful way of thinking about it.
Yeah.
Threefold categories of struggle, and that is delayed and disordered communication, as in speech.
Yeah.
An absence or delay or aberrant socialisation, and thirdly, unusual mannerisms or behaviours and obsessional kinds of activities. So the three areas are socialisation, communication, and oddities.
Now, it sounds like this is now classified as a spectrum disorder.
Yes.
And presumably some of the kids that we used to think were just a bit of a funny kid or with a few eccentricities are now classified as autistic.
Yes.
Would that be where the difference in numbers comes in? Because I think even when we were students, it was quite a rare disorder and had to be very severe before somebody actually put a label of autism.
Sure. You're quite right in part, although it seems to be not the total explanation. So one reason for a shift in prevalence, frequency, is the issue of the changing goalposts of spectrum, Gaussian curve distribution, which is recognising more children with those triad of complexities. However, though that is certainly a factor, and DSM-4 said one lot of criterion, DSM-5 is saying slightly variable criterion, it doesn't explain the huge shift. I think awareness of the diagnosis has been a factor. Higher community awareness of the possibility of these unusual things being now to be considered, at least in the spectrum. I think the education of professionals has changed that. So speech therapy people, psychology folk, as well as medical folk are more aware and I think more inclusively, I suppose, trained to be suspicious of it. Having said which, there's a lot of variable research which is looking at what environmental factors might contribute.
And of course the mums are all worried, you know, did I eat the wrong thing while I
All
was
of that.
pregnant, and you know, was my father's smoking a problem?
Sure. Yeah.
Is there anything that GPs can hang their hats on, or say,
I'm
look,
afraid it's
definitely not
all
or definitely yes?
not yet. Well, there's some
Apart
things
from
that
the measles,
definitely
mumps,
not.
rubella
The
vaccine.
immunisation controversy should be well and truly unresurrected. But the other things are research questions, like excessive levels of testosterone intrauterine is being raised as one example. The breakdown sex hormones out of plastic is being raised as but none of this has been substantiated yet. I think what we do know that is relatively new confidence about the spectrum is that it is a neurodevelopmental issue, as in structural. The nature of the structural deficits are still being defined. Some have been recognised. So there is, as for ADHD really, there is a neurobiochemical structural issue that is coming to the fore rather than environmental issues as used to be in years ago.
Yeah.
And making many mums feel difficult and troubled because the implications that it was their
fault somehow.
Their fault because they were too detached, too cold, and that is certainly not any longer thought to be relevant.
So if, as a GP, you know, we do a lot of baby checks and immunisation stuff in that first year of life, and then we sometimes don't have a great deal of contact with kids until they're kind of going to kinder or school and
Sure.
catching colds. What sort of clues might occur to a GP with that very intermittent exposure to
Sure.
the child that would say, you know what, I think this child might have an autism spectrum disorder?
The early signs that are possible, not definitive, but possible indicators that it might be an emerging spectrum disorder. I'm talking about issues in the first 2 to 3 years of life at the moment, are things like 10-month-old children, for example, normally turn to their names.
Mm-hmm.
Children with autism do not. Children at around 10 months to 12 months, even before they've got much speech as opposed to language, tend to point to things that they want or point to things that they've seen and share that information. Children in the spectrum don't do that, either a definite pointing for I want or directional kind of pointing to inquire.
Yeah.
The other thing which has fairly recently been identified as a possible alert, not proof, is a change in head circumference. In the first year of life, if the child was born within the 50th percentile normal head circumference, at around 3 or 4 months in children with suspected autism, you see a rise and crossing maybe 2 percentiles, and it's not hydrocephalus, for example. So head circumference change, pointing absence, turning to name absence, and then delay in communication, as in words, which is a very variable thing anyway, but or loss of the words they had is always a worrying alert.
Would you immediately think autism in that case, though? That would
you'd check
start
hearing first.
wondering about
Or
hearing
other-
or head injury. Or
That's right.
something
and
a
you've
little more
always
acute.
got to do a thorough consideration by history about developmental sequences, as well as, of course, a neurological general physical exam. The other thing which is fairly crucial in early detection, and that's the absence of emerging pretend play. And around about any time after 12 months, 14 months, children are wanting to feed Dolly with a cup or a spoon, or put animals in a truck and take them off somewhere other, and use cars, for example, particularly if they're boys, for imaginative play. The absence of pretend in imaginative play, or the delay in it, is another significant alert.
So what would an autistic child do instead?
If it's a car, and very commonly, and the boys like cars and trains, they will not, this is an overview, it's not
Yeah.
absolute for all, but it's common, they will not see the whole of the car and take a car on a drive and make appropriate noises. They will focus on the wheels of the car, or just the colour of the car,
Yeah.
or just something that is part of the car but not the whole. And that's not normal play.
Yeah. When can you apply a label to
Ah,
a child? When can
what's
you
the
go?
earliest age?
When's the aha moment where you can go, that definitely is an autism spectrum disorder?
I think for most of us the experience is we love it to be as early as you can have it, because of early intervention, which can be very effective and helpful. And you're doing well if you've been pretty confident about the diagnosis is between 18 months to 2. I think you are, because of the developmental variations in children, the time of emergent useful language is very variable. I mean, you get single words hopefully any time from 8 months to 10 months onward, moving to word combinations around about 14, 15 phrases and so on it goes.
Yeah.
So you've got that variation anyway. But if, and it's a collection of things, it's not an isolated thing that is the alert. If in the presence of a child who didn't turn to its name, didn't point, doesn't eye gaze, is limited or absent in any words that are recognisable, or has lost the ones they had, and is not pretend playing,
Yeah.
you're getting very, very suspicious, and they really should be assessed.
All right. And it would be appropriate, even in a child that young, to then write a referral to where from the country?
Not in all states of Australia, but in Western Australia, it is required that there are 3 professionals who assess a child and come to a consensus agreement, and that's medical person, usually paediatrician or psychiatrist, a clinical psychologist, or a speech therapist. So that team of 3, however they do it, and there are specific tools to do the diagnosis, need to have done it according to DSM-4 or ICD-10 criterion, and agree. And where can you get that, particularly for rural people? The Disability Services Commission have a country team, and it is available for any suspicious assessment of possible autism, not necessarily in association with intellectual disability, although it commonly is. But the country team, they are quite quick, relatively speaking, to metropolitan availability, to seeing children referred with or without intellectual disability.
And presumably if we wrote a referral directed to Princess Margaret Hospital, it would be redirected in the correct place?
Absolutely.
Trevor, some kids don't seem to be diagnosed until they actually hit school or some kind of formal group or education. And then there's all these tags, auditory processing disorders and Asperger's and high functioning something or other, and two of my little patients who are something else not otherwise specified, which I always thought was a horrible label to put on a child. How do you find your way through the maze and sort of help the families deal with the very specific needs of their child?
I think one of the things which is significant is that we're talking about a spectrum.
Yep.
And why is that important? The thing is, like all things biologically, they fit into a Gaussian curve distribution. And in this instance, symptomatology and severity levels are not absolute. So you've got some children who are at one end of the cognitive spectrum with severe autism. There is moderately severe autism. There's mild autism in the sense of spectrum. So that's point number one. Not all autism is the same autism.
Yep.
The other thing which, as you read that alarming list of not otherwise specified and so on, is because autism is not necessarily a singular or pure condition. That's not to say that it is not existing, because it is 1 in 160 and 150 in Australian research. But I'm really leading to the associated phenomenon, the comorbids. If we were talking about ADHD, for example, in Attention Deficit Hyperactivity Disorder, you have very common associations, 40 to 50% of learning difficulties, anxiety and depression, and things like that, oppositional defiant disorder. Now, autism is not different in the sense that it's got its own raft of commonly associated issues, like intellectual disability, which we've already alluded to.
Yep.
So I can think of children where that was obvious, but the spectrum components took time to register, because what was part and parcel of their global intellectual disability and what was something different that wasn't just explained by that. So that's one comorbid issue that needs to be explored.
Quite a lot of them seem to be, rather than intellectually disabled, really very, very bright.
That's right.
Just a little bit odd.
That's right, and high-functioning autism, as we call it, is very, very much more prevalent and common than I remember it 20 years ago or so. Maybe we missed it. But that's part of the spectrum now.
Yep.
And high-functioning autism needs to be, and that can be masked by brightness or masked by not thinking of it because, well, they're doing quite well, but as you say, they're a bit funny in some way. But the other comorbids that are common is, in fact, ADHD. About 30% of children with autistic spectrum also have attention deficit disorder. And it's therefore, depending what primarily presented, people might have gone down that pathway. And that's not inaccurate, but it wasn't the core major. And we're back to the old adage that we all know, that and certainly in paediatrics, that the issue is likely to be revealed in careful history taking, followed by observation of the child's appearance and observation of the child's performance. Full developmental history, observation of appearance, observation of performance. And sometimes, for example, I can think of one situation which comes to mind, a very unusual child, specific learning difficulties with borderline capacities, who presented with quite classical ADHD and responded favourably to treatment. But that then unmasked the other things which weren't so clear, and so the autism diagnosis was able to be made.
As you were saying, you know, the parents are either extremely resistant to a label for their child or extremely desperate to get a label that's actually recognised by the education department.
And so the teachers.
My poor little kids with the not other PDD and OS.
They don't get it.
They didn't get funding.
That's right.
Which was extremely difficult for the
Very
parents.
difficult.
So when, as a GP, we're interacting with autistic children,
In the
hopefully
clinic situation.
in the clinic situation, and hopefully avert the tantrum.
Sure.
You know, what happens when you've got to give them an immunisation
Sure.
and they're old enough to hit?
Sure, and bite or whatever, yes. Be very, very cautious not to touch. Or if you are going to touch, let it be in the security of a parental embrace if the child is receiving of that. Now, that's not to say that all children with autism react aggressively to touch, but it needs to be considered and avoided. I mean, if you're going to give them an injection, that's arguably touch, but I'm meaning that approach of meaning to be reassuring kind of touch. You need to be cautious about that. A play area that's child-friendly and interesting things, but not too much. Overload is hard for them to cope with.
Yep.
They like to build blocks, and nice soft plastic things which can make towers is worth having if you can. But I think the more important thing is to be strictly on time if at all possible. They get very agitated in new circumstances which they don't understand, and if the parents have gone through reassurance and they're sitting there, nothing's happening.
Yep.
So that's a very practical thing.
When you talk to a small child, you quite often, you know, squat down and talk smilingly to their face and look into their eyes and, you know, maybe distract with a few toys. Is that an approach that's a bit overwhelming for an autistic kiddie, or is that
how close
a
you
reassurance?
How close you get. But I think finding something which you suspect from your observations is of interest and drawing their attention to that, that's a good thing. Getting down to their level is always helpful for all children, in my view. But proximity needs to be guarded, I think. And I think when you come to the immunisation, I think the less that's said about it, the better. Just do it.
Yep.
Get it over and done with quickly, while distracting has happened.
Get the nurse to do it.
Oh dear, oh dear.
It's a complete cop-out, isn't it? What's so different about how these kids learn and integrate new things and new skills and experience?
The commonly used visual symbol of autism is the jigsaw puzzle with bits that don't fit together.
Yeah.
And I think that that's quite a sensitive expression as an icon of autism, because that's their world. They are struggling to make sense of it. They don't understand communication readily. They can be taught it, but it doesn't happen spontaneously in a smooth way. So how do they learn? One of the things which is very, very helpful is to realise that communication by speech, which we all do, and some of us too much, is overwhelming and hard to comprehend, if that's all it has done. My point being that it's very, very commonly found that children learn best, if they have autism, by visual indicators. So, for example, you're wanting a child with, because it's a common problem, to advance with toilet training.
Yeah.
Okay, you might be able to say, well, you go to their toilet and make sure the seat's down, blah, 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 all of that kind of thing. But diagram.
Yeah.
This is you. Pull down your pants. Diagram, picture. Sit on the toilet, diagram, tear off the paper and wipe your bottom or get mummy. Toilet, next diagram, flush, pull up your pants, nice new diagram, next diagram, wash hands. That visual thing, and accompanied by words, makes learning much more accessible. The advent of the iPads and that kind of thing is brilliant for children with autism. At the Autism Centre, for example, a relatively new centre built by the Autism Association of WA, if you go into their therapy rooms and their play rooms and so on, several iPads will be around the wall and the children just go and do it. They're very good with technical stuff. So I'd strongly encourage any work or interaction with children to think of the and to tell parents, if they don't know, to try to teach a new issue with sequential visual display.
Trevor, when the parents come to see a GP with a child who probably has an autism spectrum disorder, they're terrified their child is not going to have a future. And they're also quite terrified about the next kid that's in utero at the moment or that they're planning. Is that child also going to have an autism spectrum disorder? What can you tell the parents about the kind of prognosis of their child? And is this a genetic thing? Like, can we reassure them that the next child's likely to be a normal?
We're seeing increasingly now in our child development centres families that have got 2 or 3 children with autism, which I don't think was something we used to see or used to recognise anyway.
Yeah.
Now, that is suggesting a genetic component, but the genetics are yet to be defined in terms that you can be reassuring or not reassuring about.
Yeah.
But I think my strong encouragement to those who have the privilege of seeing families like the family GP is to, when you're seeing the child with autism who is either about to be diagnosed or has been, use every clinic opportunity, if you can, to inquire about the progress of sibling
The other
number
kids.
2, number 3, or whatever the situation is. As to reassurance, I think the honest thing now that it is not likely, but it is known to happen, and we'll watch carefully. I don't think we can put a figure on the risk factors at this point, but I think we ought to, in fairness, let people know about. Then we need to balance it, that having a diagnosis of autism doesn't mean, it's sad because you, in one sense, have lost the child you thought you had, but about 20% of children with ASD spectrum disorders get academic qualifications. They may be, and I'm very rude when I say this, go to the sheltered workshop called the university and be involved in IT, for example. That's an avenue which is it doesn't involve people necessarily, it doesn't involve communication other than visual, and so there are things that they can do if they've got the cognitive capacity to do it. 30% of ASD are in employment, and certainly the Autism Association of WA has been the leader in the whole of Australasia for success in getting children and young adults with ASD into employment, and 25% have friendships in which they can share activities and interest with, and of course some get married.
Yep.
But a lot of that is dependent on the severity level that we talked about before, which end of the spectrum, and what are the comorbids.
Yeah, now, as a GP, you often feel entirely useless because most of the treatment for these children and young adults is happening in the allied health sphere. I know you've mentioned several times that they get terribly anxious and terribly depressed. Is there a role for any kind of medication with these kids?
And I think that I'd like to preface my comments by sort of saying that a child who has ASD, and that has its own features and challenges and management issues, is a person. And I think over the years it took me a wee while to sort of let that embed itself adequately into practice. For example, what I'm alluding to is that children with autism have strange mannerisms which we call stimming.
Yeah.
And I suppose we tended to say, well, of course that's what people with autism do, but without asking the question of what does it represent. Stimming is repetitive mannerisms which are...
So the things that they used to call tics but aren't really tics.
They're different from tics, yes. They are repetitive actions which I think when you look at it are expressive of anxiety. I remember one young woman that I saw some years ago who was non-communicative but very cognitively aware otherwise. And we thought her stimming and her moods were just part of being autism. But she was going into puberty and she was very depressed and anxious. Medication, fluoxetine or something of that nature was extremely helpful and transformed her.
Yep.
The other thing which is common in about 30% of children with autism we're finding also have ADHD and respond extremely well for that part of their problem of attentional organisation with stimulus. And the third thing I wanted to mention, because it's common
So
as
stimulants and anxiolytics at the same time. It seems to work.
Sometimes it is, risperidone has been wonderful for particularly the confused, anxious aggression of some of the children with ASD as they move towards puberty.
Yeah.
The other thing which might need pharmacology, but obviously before that, thoughtful diagnosis, is a higher 25% of them who develop epilepsy in adolescence. So what might be thought weird behaviour might in
Was
fact
actually be some kind of temporal
neurological,
lobe petit mal seizure.
or they actually have grand mal. And so my point being that they are firstly people.
As a GP, I'd be quite reluctant to start prescribing something psychoactive like fluoxetine or an anxiolytic or Seroquel for a child or an adolescent, and I'd be all at sea trying to work out a dose appropriate. Is this something that we could work out just with the help of the local visiting or resident paediatrician, or is this something where you'd actually need a child psychiatrist to be involved?
I would strongly suggest that GPs look to see with advice as to which psychiatrist they might form a relationship with, just to phone and get advice from. Certainly the visiting peds would be a very, very welcome source of support and guidance for that. But I wouldn't put aside the possibility of maybe ringing the local CAMS.
Yep.
Or the nearest CAMS if there is a psychiatrist that they could develop a relationship with. And that is an inexpensive way, if the professional is agreeable, to work in partnership and get advice and encouragement and backup. So I wonder whether it would be very appropriate to think of how to almost formalise that linkage with the child development centres, the visiting peds, and or
The adolescent and children's mental health.
Yeah.
Yeah. Well, as a GP, the other thing we seem to spend an inordinate amount of time doing is writing GP management plans and mental health care plans, which are all designed on a ticker box formula for a middle-aged adult with depression and therefore don't really fit an autistic 13-year-old. If we were going to go to that trouble for an autistic child, where would we get our best bang for buck?
I think that's a very concerning issue. My first thought about that, and it's difficult, again, resources are not plentiful in many ways for what you might want. But that raises the question, I think, that, as we've said before, not all children with autism spectrum disorder are the same children. And so having a diagnosis doesn't automatically mean that's the package.
Yeah.
I think you have to go back to the clinical question of what is the dominant need for this child who's got autistic spectrum disorder, by which I mean, in the triad, is that mainly that you need to focus on strengthening communication, in which case speech therapy is obviously a way to explore. Is it behavioural, antisocial or lack of, in which case that might be clinical psychology. Or is it socialisation, and OTs are very good, that kind of thing.
Yeah.
So I would encourage people to, in their working out of their plan, not to necessarily go comprehensively to get everything, but to ask the clinical question, what is the dominant need this year, and work with that. My next point would be that I think hopefully all families with a child or children with ASD hopefully are linked up with one of the organisations that specialise in it.
Yep.
The only organisation in Western Australia that is available through the whole lifespan for children and young people and adults with ASD is the Autism Association of WA.
Yeah.
And they have about 8 programs ranging from early intervention to school age, to employment, to residential care, support for parents, that kind of, and in it, the accessibility to therapies, and in it also, if it's very challenging behaviour, they have at least 3 clinics a week where a psychiatrist experienced in autistic spectrum disorder can see mostly those who are in residential care in the organisation. But relatively recently, last year, I think it's 2 clinics a week, something like that, by a child and adolescent psychiatrist who will see any child with challenging behaviours who in the spectrum, whether or not they are registered with the Autism Association or not. So there are resources.
Respite?
The association, Autism Association of WA, offers respite.
So, and that's residential respite or
Yes.
in home care? Is that not a terribly threatening experience for
First time
children?
can be difficult, but they seem to, you're selective. It doesn't suit all. So it may need to be home respite rather than residential.
Do you have any happy stories? People who've been outstanding successes, children who've
Well, some people will immediately
bounced
say,
in?
look at Bill Gates, look at Mozart, look at, and so it goes on. There's a whole range in history of people which you can see in the spectrum who, within their areas of exceptionality and so on, have been doing extremely well. The one which personally came to mind was a young man who is now in his 20s, I've known for years and years, who invited me to his art exhibition. You know, things like that, which was just lovely. He found an area of achievement and possibly employment in industry.
And our thanks to Professor Parry and to Dr. Olga Ward. Now, if you're interested in paediatric development and autism in particular, Professor Parry has suggested some resources, the links to which you will find on our website. That's ruralhealthwest.com.au. We're back on the 6th of May with a special program that draws on some of the new trauma simulation used at the WA Trauma Education Committee's Western Trauma course. It should be well worth joining us for that. We'll see you then. For now, I'm Jerry Gannon. Thanks for watching.